see. Good afternoon. I don't know if this is on or not. Good afternoon. I think I have to hold it there, yeah. Good afternoon, everyone. This is a good sign. Everyone's full of life and energy even after lunch. That's always the scariest part if you get the 1:30 slot. Well, welcome and thank you for coming. My name is Lenny López. I'm one of the senior faculty here at the Disparities Solutions Center, and all of us are excited to get started, since sooner or later we'll fall behind schedule and we'll be in trouble. I just want to do a little housekeeping before we get started. And on your tables there are reviews. If you could please take some time to fill that out sometime during the presentation. Towards the end, they'll be collecting them. And if you have any from earlier in the day, we need all this information in order to continue to make the program excellent and outstanding. I just want to give you a sense of the structure of the panel. Our focus really is to do as much interactivity as possible in the hour and a half that we have together, maybe now an hour and 20 minutes since the clock's already ticking. And our speakers will talk for about 15-20 minutes. There'll be time for a little bit of Q&A, any clarifying questions. And after that, what we wanted to do is something that we're calling an opportunity to do create a burning question from each table. And this helps everyone to come together and talk about a question they'd like to discuss with our panelists. And it also prevents the anyone trying to monopolize the Q&A, which can happen when people decide to have comments and 8-part questions. So this is an opportunity for the teams to come up with a question that's democratically chosen as the burning question for each table. Okay? And then we'll discuss it all together, and our panelists will have an opportunity to share their experiences. Any questions about that style? Refreshments are in the back. Restrooms are down the hall. You'll figure it out if you need to use one. And just wanted to get started. We're lucky enough to have two leaders in the field here to talk to us about our panel title, Laying the Foundation, Building Measurement and Monitoring Infrastructure for Equity. And the amount of interest by your presence shows that this is a very hot topic. Starting off will be Dr. Elizabeth Mort, who's the Associate Chief Medical Officer and Vice President of Quality and Safety at Massachusetts General Hospital. And there are longer bios in your book, so we all know you can read, and we'll let that be your opportunity to read more about Dr. Mort. And then that'll be followed by Dr. Rawlins, who's the National Medical Director for Racial and Ethnic Equality Initiatives at Aetna, and he will be going second. So I'd like to introduce Dr. Mort.
Thank you very much. Now, can you all hear me? Can you in the back hear me? Okay. Well, I'd like to thank Lenny and Joe and others in the Disparities Solutions Center for inviting me to come speak with you this afternoon. I have had the privilege of working with the Disparities Solutions Center on this journey of ensuring that we are measuring, monitoring, and improving care to make sure that it's equitable for all. And we've been on this journey now for how many years? Close to a decade. It's close to a decade. And at Mass General, those of you who were at lunch had a chance to hear from Dr. Peter Slavin, who's the CEO. He has been a very, very important part of our program and our journey. What I'm here today to talk about is a layer down from that. I mean, Dr. Slavin talked about leadership and setting the tone. What I'm going to talk to you about is how do you lay the foundation? How do you make sure that equity is considered in your usual management cycle? And how do we actually measure? So as Lenny said, I'm the Vice President of Quality and Safety, and my background is in measurement. So I have really been very, very involved in the details here. Now, I'm going to start and end with this same slide. This you could consider as kind of a checklist. If you take these 6 points and take them back to your organization and follow them, I think you'll have success at making the issue of equity a high priority in your organization. So you all know about the Institute of Medicine, and there's 6 pillars of quality, safety, and so on. Equity is one of those. I think hearkening back to the Institute of Medicine in your conversations about quality and safety, reminding everybody, oh, equity, that's one of the pillars. So it's really fitting into your overall framework of quality and safety. Now, you want to ensure CEO and Board of Trustees support. You heard from Peter Slavin. We also talked to our Board of Trustees. Joe Betancourt has been to the Board of Trustees many, many times, basically on an annual basis, to make sure that they are understanding the issues. And I'll tell you a story about that in a few minutes. I think it was a real landmark comment from one of our Board of Trustees. Actually, it was the chair at that time. Now, in order to nurture the issue of equity, focusing on disparities, you have to embrace it, just like you would embrace any kind of management and measurement initiative. Develop standing committees or establish a department with the explicit charge of monitoring and managing equity. You have safety, you have quality, you have infection control, you have equity. It should just roll off the tip of your tongue. It's not a science project over here. It's part of the way you set up your management. Now, some of you may be in the position to organize your management structure. Some of you may need to talk with people who do have that position, but it should be part of the way you do business in a healthcare organization. Now, we have established at Mass General a quality and safety goal setting program, and this is a check in our management structure every year, and it's goal setting season right now. It starts about September. We do our goal setting on a calendar year basis, and about now, we go across the institution and talk to all the constituents who have accountability for quality and safety and ask them to give us information about their performance or the institution's performance and give us what are the 3 things that you are really concerned about. Give us 3 candidates. This is your opportunity to influence what the institution is going to focus on. And obviously, the point here is that we make sure that we're involving the committees that are focused on equity. Policies. Medical policy. There's a medical policy committee in most organizations. It's usually not the committee that you raise your hand and you can't wait to get to, because often you're talking about some pretty dry things. Well, Joe was very, very smart, and he said to me early on is that, you know what we need to do? Measuring data by race and ethnicity should be part of the way we do business, and to ensure that, we should have a policy about it. So we wrote a policy. It's about this long. Doesn't have to say very much, but it went to the Medical Policy Committee where we talk about all sorts of issues related to the way we provide care, and it was approved. And essentially what that policy says is that whenever possible, when we are measuring quality or we are looking at adverse events, when it's possible and feasible, look at race and ethnicity. It's a policy. Annual report and presentation to Executive Committee and Board of Trustees. So as the Vice President of Quality and Safety, I have calendars and schedules and meetings, and in my head I have a system. Are all of the right initiatives bubbling up through the right committees, and are the right messages getting to the quality and safety leadership at the hospital and ultimately to the Board of Trustees? And we don't use the Board of Trustees only to brag. We use the Board of Trustees as a way to say, we're worried about this. We want to share our worry with you. We need your help. It might be resources and the like. So an annual report and a presentation to the Executive Committee is really part of the way we have developed the foundation. So I'm going to get into the details, but do these feel right to people? Yeah? Okay. So here is the quality and safety government and constituent representation at Mass General. So on the top is the Board of Trustees, and under that is the General Executive Committee. Let's see if I can, is there a pointer on this? I think so. So this is the General Executive Committee, and this is where they approve big budgets and building buildings and that sort of thing. Well, it's also where they approve quality and safety goals and monitor quality and safety for the institution. Our Board of Trustees developed a subcommittee on quality. This hasn't been there since 1811 like the hospital. It's only been there since 2000 because the Board of Trustees chairman thought quality and safety as an overarching discipline was important enough that we need a subcommittee on it. So we've had that for about 12 years. I think it's helped tremendously because the board's dealing with lots and lots of important issues, but this subcommittee is focused on quality and safety. So underneath this layer of the Board of Trustees subcommittee and our General Executive Committee, we have two really important committees, both of which involve oversight and monitoring of equity. This is our Quality Oversight Committee. This is more or less the funnel. This is chaired by the Vice President of Quality and Safety. This is the committee that reviews goals, monitors programs, and really is responsible for identifying where inequities or imbalances in the system lay and make sure, whoop, it's going up to the board. This committee, the Quality and Patient Safety Committee, many hospitals call it the Patient Care Assessment Committee. We switched the name a little bit, but essentially, we met this morning. We meet every month for 2 hours, and the committee is comprised of QA chairs from all of our clinical departments, so surgery, medicine, urology, etc. And we talk about lots of quality and safety agendas, but we also talk about cases that happen in the institution. So that's that department. So that's one layer. Now, these two committees, this focuses on safety, this focuses on our regulatory readiness, and then you have the constituents below. So that's more or less the pyramid. Now, obviously, I don't want you to read all the lines in the light blue boxes. I'm making 2 points here. Now we have the top layer all, compressed, but you can see that under all these committees, here's the Quality Oversight Committee again. Remember, that's the big funnel. This is the functions, they're more or less what I mentioned, and then here are the constituents that sit at the table. I bolded and put a yellow star next to the Disparities Solution Center because it's very important that that committee, in this case we have a center devoted to equity. But it's very important that when you decide who you're going to invite to your committee, that it should be just routine. Of course, Disparities Center is going to be there. Infection control, perioperative care, nursing, and disparities. It's just the way you do business. And that's where you have to get, I believe, in order to make the foundation really, really strong and durable. Okay? These committees change, and we have to keep them up to date. So I mentioned the annual goal-setting process, and this is another important foundational tactic that helps keep us on track and ensuring that we're being comprehensive and including all 6 pillars of the Institute of Medicine's quality definition. So we've been doing this goal-setting process since 2008. When we started this, there were about 6 ellipses around this data hub. This is 2012 or 2011. You can see the number of ellipses or inputs has grown. The idea here is that as a quality and safety function, our malpractice insurer actually said to us when they evaluated our program, they said, you have to pull together all your data. Where's your data hub? And I don't mean a fancy database. I just mean a process, a place where every year people from around these departments are asked to submit their information. And I just reviewed that for a moment. But I put stars next to the areas where we in particular are looking for input on race and ethnicity and equity. So we have the Disparities Committee. We get lots of good information from patient family advisory committees. We get patient narratives and patient experience surveys. And one could go on and on and on because many of these other departments that submit information, you could be talking about race and ethnicity. But we have areas that we look specifically for those issues. So again, we ask these departments, submit your performance data and tell us what you're worried about. Collecting data on race and ethnicity isn't all about taking your administrative data and splaying it. It involves many, many kinds of data. Stories, indicators, surveys, focus groups. And we've used pretty much all of those tactics in trying to collect information to really enrich our quality and safety program. So that's our data hub. And after we collect information from all these areas, we look for common themes, and we do some qualitative combinations, and then we do some goal drafting, and we run it through this approval process. And it gets all the way up from the compilation of potential targets by the center through the Quality Oversight Committee, Board of Trustees, the Steering Committee, the General Executive Committee, and ultimately the Board of Trustees. So what I've just gone through is what I feel good management hygiene. You should do this for anything you care about in quality and safety. And my point is that disparities, or the focus on equity, should be treated the same way you treat any other important aspect of quality and safety. And if you look at your structure, and equity is a science project over here, You haven't fully embraced it as part of the way you operate. Whoop. So last year, this was a goal that we're still working on for the 2012 calendar year. It's a really broad goal: enhance our quality and safety measurement and performance improvement infrastructure to advance 6 IOM aims. And you might say, well, what does that mean? I'll translate that for you. In hospitals, the numbers of requirements that we've been asked to complete or fulfill has grown probably 5-fold in the last 4 or 5 years. So we have an incredibly large and growing number of requirements and inputs, and what we've spent a considerable amount of time this year doing is taking a look at all these different programs and trying to figure out where the triangulation is. For example, when you look at all the different requirements from the state, from our commercial payers, from CMS, readmissions keeps popping up. So rather than work on 4 or 5 different readmission projects, we look at all of the readmission requirements and try to come up with one goal with kind of a maximum target and work toward that. So that's what that's been about. And you can see the bullet points are more detail. But the yellow I put here because prioritize our efforts and highlight measures of particular importance: patient experience, racial, ethnic disparities, and end-of-life care. When we go through this, what we do is we look at all those inputs and we run it through different filters. One of the filters is how important is this, how actionable is it, what's the threat to safety. Another filter is how important is this to the everyday excellence that we need to provide. We want to make sure we've got the fundamentals down. What about the Institute of Medicine pillars? So again, we look through what we're doing, we run it through those filters, and we make sure that we're being comprehensive. So how do we report out on our data? We have an internal dashboard, which is internal to the Mass General's internet, and probably about 100 people have access to it, anybody with accountability for quality and safety. And every year we change the face of this dashboard to reflect the goals for the year. So here's calendar year 12. Efficiency and throughput, regulatory readiness, adverse preventable events, patient experience. Whoop, disparities report. We produce a disparities report every year, and we put it right there. And we make sure that that disparity report gets reviewed, edited, we challenge ourselves, and we then distribute it as a report around the organization. And it's right there for everyone to see. Now, what's in that disparities report? It uses many different types of data, many different types of technique to tell the whole story. And we've called it the dashboard, but that's really a misnomer. It's really a report, and it tells some very important stories. When we first started producing this, I remember when we took our administrative data and showed it to our chiefs. Our chiefs were not aware of the race and ethnic mix of the patients that they serve. So I was thinking, boy, this is really basic, but it was really important that people understood that. So here's a chart that shows patient diversity at Mass General, and the distribution of race, ethnicity at Mass General is really the mirror of the population of Eastern Mass. And there's more diversity in our pediatric population and our OB population. Mass General has many community health centers, and we have a new OB program. Well, new is about 2004, 2005. So we brought more patients into the hospital through those programs. And I didn't put the chart up there or the pie chart for OBGYN, but I can tell you the chiefs who own those departments kind of swelled with pride. See, we take care of a diverse population, more diverse than the population at whole. So all of a sudden you're getting the chiefs aware, they weren't really aware of that, and feeling proud about it. In addition to basic epidemiology, we take a lot of our data, which I'm not going to show you, so our patient satisfaction data, our national hospital quality measures, and when we get the ends large enough, which is an issue sometimes, we display them by race and ethnicity. But we also ask ourselves, you know, the literature has shown there's inequity in care for patients with diabetes, in care for patients with cardiac disease. What about patients who come to the emergency room with pain associated with long bone fractures? The literature says the time for pain control is different by race and ethnicity. So we have gone and hunted up whether or not those issues are true for our patients. And we found, for example, several years ago, this was in one of our health centers. In 2005, 17% of Latinos with diabetes were in poor control. Hemoglobin A1C greater than 9 is poor control. Their rate was 17.5% versus 9.1% for white patients. So we put that up there. We talked about that not only internally, but we put it on our external site, which I'm going to come to in a moment. And we asked ourselves, well, we have to fix this. And this is the story that I want to tell you about the Board of Trustees chairman. I remember Joe Betancourt was presenting this, and the committee, the Board of Trustees committee said, well, do you think the doctors and the nurse practitioners do things differently based on the race and ethnicity of the patients? And Joe said, no, they probably don't. And you know what? That's probably the problem, that you really haven't examined the cultural differences. So you're all nodding, right? This was a moment where I think the other epiphany is that providing the same care is not necessarily providing the right care. So this, I think, launched a new understanding of our board that, okay, well, tell me what these different populations need, navigators, et cetera, et cetera. So I think that was the moment that I felt we really had hooked the board. I'll never forget that. Anyway, this program involved employing a navigator to help patients understand the importance of hemoglobin A1C control. We've made some strides, although there's still a gap, and we're not done. So the last thing I want to point out is that we have a big focus on transparency and data at Mass General. This is the Mass General home page. Voila. And here's the quality and safety report card right there. So if you go to our home page and you click on this, you'll get all sorts of information about quality and safety. We provide information on all 6 of the Institute of Medicine pillars. This is the page that says providing equitable care. And when you drill down into this, you can do it later today if you want, you can see information about race and ethnicity. There's Dr. Betancourt, and if you scroll down, what you're showing here are the National Hospital Quality Measures by race. We also show stories, and that's where the story about the diabetes control comes in. So that's the story of what we've been doing over the last 8 years. And just to remind you, or just to close, I think it's really important that looking at equity is part of the way you do business. It has to be valued in the same way that hand hygiene, we all know that's important, hand hygiene, or aspirin on arrival. It has to be thought of as important as those things that we sort of take for granted as are important. The CEO Board of Trustees support is key. Standing committees, it has to be considered as a filter. The Institute of Medicine goals, are we looking at equity? Policies, as basic as they are, they're very, very important to keep everybody focused. And then the annual report. So that's our story. And I think we'll have a lot of time for discussion and dialogue about it in a few minutes, right?
Mm-hmm.
Questions now?
We could spend 5 minutes of any clarifying questions for Dr. Mort.
Yes?
You mentioned that Dr. Betancourt responded that perhaps professionals were not doing any different between practitioners and physicians. Something that has been coming to my mind continuously since I attend these conferences, what about whether you're tracking data on your professionals? What is the ethnic background, the cultural background, the language of your physicians, of your nurses, and all the staff that work in your hospital? Do you do that?
We do. Language, and it's a part of our Disparities report. We talk about our interpreter service, and we take it very, very seriously. We have many different languages spoken by our providers, but not nearly enough to meet all the different needs of our patients. So we have a very robust interpreter service, and we have in the inpatient something called IPOP, which is essentially a phone service that you can bring to the bedside and dial up whatever language it is that you need. But we actually spend a lot of time on language, and we think that language is critically important as a factor that may result in a non-English speaking patient, could result in lack of equity, and that's why we take the interpreter service, particularly in the emergency room where things happen fast. Interpreter services are really key. Yep.
I know that the statement has been made, if I give good quality care to everybody, it should, everyone should receive the same type of care, same level of care. But has it been thought to do an assessment of the patient? Because you just can't say Spanish people feel this way and Afro-Americans feel this way, but there's certain assessment questions that can be asked of a patient that would give you more of an idea of where they're coming from and really help you with taking care, going forth with their clinical care.
Yes, and I hope I didn't give anybody the impression that sort of a one-size-fits-all based on race or gender or anything, but we put a lot of effort into cultural competency and really trying to understand where the patient and their family are coming from. I wish... I don't know of any in the primary care ambulatory setting that are that explicit. I think people are given cultural competency training, but I'd love to hear what you have, because that might be something that we would want to look at, particularly as we move into the electronic medical record, where it's really quite easy to present practitioners with decision support. Nurses at the bedside on the inpatient side, I think they get really intense cultural competency training, and they may have specific questions to the point you're making. I'd love to hear more from you. Maybe we can talk afterward.
Hi, Don Goldman from IHI. And this is a little bit off the measurement topic, but because you mentioned some innovative approaches to reducing inequity, I'm going to ask how you encourage the front line to innovate and how you capture their innovations.
Great question, Don. Thank you for asking it, because it gives me the opportunity to talk about a research program we have every year where we encourage clinicians on the front line who have great ideas to come get some research dollars and some coaching from our clinical research program to go study it. So colorectal cancer screening, we saw a couple of things. We saw relatively low rates across all race and ethnicities, but we saw even lower rates among patients who were not white. And one of our very, very busy Hispanic practitioners, a physician, thought she had an idea. She applied for that grant. She got the grant. She worked on a navigator program and has made tremendous strides. So we try to fund people and give them some protected time. We have a couple of programs like that as one idea.
We have time for one more question.
Yes?
Data on a granular level, or are you using general categories for how you collect your ethnicity data?
How granular are you?
Well, for instance, are you looking at Cambodians and Vietnamese specific granular data, or are you looking just at the Asian population when you are looking at outcomes?
In the very next room is Nancy Connery from our admitting department, and she's showing exactly what our screens look like, but it's self-identified, so patients can self-identify them in any way they feel accurately reflects their race or ethnicity. When we report out on data, however, we tend to, for N purposes, collapse some of these categories. Otherwise, the findings would be getting so detailed that you would sort of lose the message. But yes, we do ask, I think according to your definition of granular, yes, we get granular.
Showed up at a community health center, and they immediately assigned her someone who spoke Creole. There was a disconnect immediately. They didn't understand what she was saying. For more than an hour, they couldn't treat her. So when you do not go down the granular level, do you take into consideration that someone who speaks Creole is not really a French-speaking person?
Yes, that's an unfortunate situation, but I can see how someone might assume that, well, French and Creole, but no, a lot of dialects don't crosswalk, so you have to be very careful. That's why that phone service that I was talking about, I had a patient who spoke Farsi, and her son came with her and often did the translation, which isn't ideal, and she wanted to talk to me about something that related to her gynecology issues, so out went the son, and on went the phone, and the two of us sat in front of my desk with the phone translator. I don't know where this person was, but it helped her get her message across. So you can't make an assumption that Creole and, where was the other patient from? Senegal? French from Senegal? No, you have to really get it down to the granular level. There are a lot of programs out there that can help hospitals do that.
Okay, thanks. Dr. Rawlins now will give us some of his thoughts from an insurer's perspective.
I'm good to go. Can folks hear me in the back all right? Yeah? Okay, good, thanks. Again, I'm Wayne Rawlins, National Medical Director at Aetna, and I lead our racial and ethnic equality programs at Aetna. Outstanding. At Aetna, we believe that addressing the needs of people of different races and ethnicities is central to our core value of meeting the needs of all the people we serve. And as you heard at lunch, for more than the last decade, Aetna has been actively addressing healthcare disparities, beginning with Jack Rowe, our CEO at the time. Now, that same commitment to addressing disparities has been captured at senior levels of the company since then, with each succeeding CEO. Now, there are three ways that we address disparities at Aetna. First is through our Racial and Ethnic Equality Initiative, which looks at addressing disparities for Aetna's members. The second way we look at it is through the Aetna Foundation that looks at providing grants to do research on addressing health equity all throughout the United States and the world, for that matter. And lastly, through our community relations and urban marketing area, which looks at really partnering with grassroots organizations to address healthcare disparities in communities all across this nation. Now, there are 4 foundational activities that are involved in the Racial and Ethnic Equality Initiative. The first is voluntary race and ethnicity collection. We collect race and ethnicity directly on a voluntary basis from our members. We've been doing this for more than a decade, and we're one of the first insurance companies to be doing this. We also developed a data dashboard tool to help us identify disparities within our membership, and we take the output of that dashboard and build targeted care delivery programs to meet the needs of our members in areas such as hypertension, maternal and child health, and breast health. And finally, we have cultural competency training for our staff. And the same cultural competency training that's available for our staff, we make available for all of our network physicians, and in fact any non-network physician who's filed a claim with us, free of charge with continuing medical education credit. This becomes important because there's a handful of states right now that require CME in cultural competency training in order to get licensed in that state. So we provide it free so people can have access to it to assist them with licensure. Now, as I said, at Aetna we directly collect race and ethnicity from our members. This is time-consuming, but it's the most accurate way to get race and ethnicity from people, and it's the best method if you're looking to do individual outreach to people in populations. Now, a primary method of collecting racial and ethnic information is on this slide. This is just a screenshot of our member portal, and we use the one-question format using the OMB general categories. I know there was a couple of people asked about granular ethnicity. We can talk about that later. There is a pop-up box that does come up that talks about why we want to get this information, what we use it for, because it's very important to have that transparency with members to let them know why you're using this information, which can be very concerning to different people. Some plans use an indirect methodology to collect racial and ethnic information. This really imputes race and ethnicity using statistical methodology based on geocoding, where you live, or surname analysis, what your last name is, to statistically figure out what your odds of being a certain race and ethnicity are. The RAND method uses them both of those together. While this method is faster and great for understanding populations, it's not the best method to do individual outreach to people because you're essentially having a real smart guess about who people are. When I was in college, my roommate was Cuban American, Armando Francisco Mar. Oops, I lost you. Bella, I'm back. Is it me or is it him? Okay, oh, sorry, I'll speak louder. And she became Susan Morales. She would not automatically be Hispanic overnight. So understand the pros and cons or strengths and weaknesses of collecting data directly or indirectly. So when you decide to do it, if you're thinking about doing it, understand what that means for you. As I said, we've been collecting data for more than 10 years now. We right now have about 6 million currently active Aetna members who have voluntarily given us their race and ethnicity. Now, we use this information really to identify and understand disparities in our membership, but it's very important that we make a promise to our members that we'll only use this information to improve healthcare outcomes. We actually do not use the information for marketing, for insurance rating, for underwriting, or for determining insurability. In fact, we have a data use committee inside the company that whenever we get a request to use this data, the data use committee has to approve it with those criteria. And if it does not meet those criteria, the data use committee denies use of this data. So it's very important that we keep our promise because we make a covenant to our members about how we're using this information. Now, as I said, to better understand disparities in Aetna's membership, we've created the Racial and Ethnic Equality Dashboard. And this dashboard takes the directly collected race and ethnicity from our 6 million people who have given it to us and combines it with medical claims, pharmacy, and laboratory information to get a picture of disparities in Aetna's membership. It's a repeatable process. We update it annually, and we add new data elements to it. And while there are a number of dashboard elements we have, the ones that I'm most proud of are the quality measures. We have more than 70 different quality measures in areas such as asthma care, behavioral health, cancer screening, cardiovascular care, diabetes, and maternal and child health. Now, this is just some of the output from our dashboard. It looks pretty. We usually look at it in Excel spreadsheets, but we've made it to this graphic. I mean, what this looks at is diabetes metrics, hemoglobin A1C. Hemoglobin A1C, as you know, is a blood test which measures diabetes control, high levels greater than 9%, usually related to poor control, lower levels, less than 7%, usually related to good control. And on the left, what we see is just people getting the test within 1 year. And while there's small but statistically significant differences between African Americans and Hispanics compared to whites and Asians, everyone's around 80%. Where we begin to see the issues of concern, of disparities, is in the middle graphic looking at hemoglobin A1Cs greater than 9, meaning poor control. And what we see is for African Americans and Hispanics, they have twice the level of poor control of diabetes care. This potentially means twice as many complications of diabetes, twice as many episodes of kidney failure, twice as many episodes of blindness, twice as many heart attacks, twice as many amputations, and potentially even twice as many premature deaths just due to this disparity. And this is the impact of healthcare disparities on an insured population. When I talk to people, I tell them that healthcare disparities are not only an issue for the uninsured, it actually impacts all populations. This is just a data map that we've taken similar information from hemoglobin A1Cs and looked at it nationally in our membership. And what we see not only are differences or disparities in race and ethnicity, but there are also geographic differences. Because of this, we've actually built a partnership, actually with a large medical group in Texas, to actually see what we can do to improve diabetes healthcare disparities in their group. Similarly, we've seen disparities in asthma. This looks at adult asthma ER utilization. And what we see is for African Americans, the ER utilization is more than 3 times what it is for whites. And for Hispanics, it's nearly 2 times what it is for whites. The terrible thing about this, quite frankly, is most of these ER admissions are avoidable. Because of this, we've built a project with our Delaware Medicaid team, whose data is very similar to this, actually, to really see what we can do to improve asthma care and decrease ER admissions for that population. Oops. Similarly to diabetes, we've mapped asthma ER utilization, and again you see disparities by race and ethnicity here, white, black, and Hispanic, as well as geographically. And it goes to the point that there are hotspots of disparities depending on what your geography is that you need to understand and know about. It allows you to focus your activities to be able to have much more traction. One of the things I just want to briefly talk about is the Affordable Care Act. We talked about some of it this morning. The most important thing from my point of view about the Affordable Care Act is it brings coverage to millions and millions of people who were uninsured or underinsured. Many of these are racial and ethnic minorities, and the coverage brings access. Access should lead, hopefully, to high quality or higher quality health outcomes for those populations. There are specific disparities, related elements that Brian Smedley talked about today around data collection and reporting, quality improvement activities, increasing the healthcare workforce, as well as cultural competency training, and two really unique elements of the Affordable Care Act are health insurance exchanges and accountable care organizations, which should bring more people into the health insurance world, but also improve the health outcomes of those populations. Now, just to end, some of the lessons we've learned doing this for more than a decade. First of all, it's critical to engage your senior leadership. They bring resources and actually organizational direction and commitment. You had heard at lunch, Jack Rowe, which is great. I love the stink out of Jack because as a physician, he gets his stuff. So it's great to have him say, as an insurance company, we have a responsibility to meet the needs of all the people who have our health insurance, not just a segment. So for him, and it was very important to make sure that we're addressing healthcare disparities. Collect the data, collect the data, collect the data. I can't say this enough. Either if you do it directly or indirectly, it doesn't matter. Just collect it, because without understanding the data, you cannot have an idea about how you want to target activities to move forward. Identifying the resources becomes important. Myself and Michelle Toscano, who's over there, and just a handful of us do this in the company as a full-time job, so to speak. But we leverage all sorts of resources throughout the company in operations and sales and marketing to really build addressing healthcare disparities into the DNA of the company. We don't want it to be just I'll speak quicker, thank you. Just something that a handful of people deals with. Know your limitations. One of the limitations we have is we use directly collected data and we use OMB categories. So we're not getting sub-ethnicity or granular data, which is going to be very important going forward. Be transparent. Let the people who you're collecting the data from know why you're using it. For a health plan, people don't necessarily trust us as much as we think that they should. So it's critical that you tell people why you're using it, and more importantly, why you're not going to use the information. Use independent standards. We had heard from NQF, NCQA, the Joint Commission, National Healthcare Disparities Report. Use these benchmarks to judge where you are and where you're going. Act locally. We're working in Delaware. We're working in Dallas-Fort Worth area. Understand what works locally, and then you can scale up and make it broader. Take bite-sized chunks. Don't boil the ocean. We're not taking care of all diabetics. We're looking at diabetics with a hemoglobin C greater than 8. We're not taking care of all asthmatics. We're looking at asthmatics who have had an ER admission. Understand your audience. This becomes really critical. The nice thing about going to meetings like this is everybody gets the disparities issue. Michelle and I spend most of our time in people that don't know, don't understand, and quite frankly don't care about these disparities issues. So it's critical to be able to speak their language and make it understandable to them and resonate with them. Because it's not what I think about disparities, it's to get them to act and do something about disparities. And there's sort of 4 arguments around addressing disparities. There's a social justice argument that you should do everything for everybody because it's a great thing. Many people say Barack Obama's president, social justice is gone, move along. There's a clinical quality measurement, which only healthcare people understand, and it's really hard to figure out if you're not a healthcare person. But increasingly, there's an economic argument. Healthcare disparities decrease productivity and waste money. Employers get that, and they really want to understand that. And lastly, there is a demographic argument. Within the next generation or two, minorities will be the majority population. We just can't go on with healthcare disparities, bad healthcare outcomes, and the significant waste around that, as the population changes. And finally, review, revise, and reorient routinely. Just like when you're sailing, you may need to tack back and forth to get to your destination. Keep your destination in mind and change what you're doing in order to arrive there safe and sound. And with that, I'm going to stop.
Thank you. Any clarifying questions? We have a minute or two for that. Yes? Yep.
Right now we're at the screening level. One of the things we're trying to understand specifically, and we actually have an initiative around improving breast cancer screening for African American women and Latino women. One of the things we try to do when we identify disparities is to say, all right, we've identified the disparity, what can we do to decrease or address that disparity, measure that, and then we build that into the sort of the way that we do business in general. There are a number of issues around cancer care which are concerning. Right now I'm worried a lot about the colon cancer issues with African Americans, but what we're trying to do is say, here's a disparity, what can we do to fix it, figure out what we can do to fix it, and then move along, and then continue to peel back layers of the onion to get deeper and deeper and deeper to understand what's going on and how to fix it. We have one more, is that right?
Sure.
One more.
So I'm curious about how you approach sort of coming from a private market sort of company rather than a research organization. If sort of some of the information that you find out from looking at these different types of data are shared among other companies that you might have competing interests against, or how much of this are you left to public sort of use for general advancement?
Yeah, I mean, that's actually a great question. We have this dialogue back and forth about what's your secret sauce, what you consider proprietary. We believe strongly that it's not up to one company or the responsibility of only one company to address disparities. And I know that there are other folks from insurers here, and one of the things we do is spend time in meetings like this and show people what we're doing and what we're doing to fix it, because our goal is not just to have Aetna addressing disparities, but to have all entities that are able to, public and private folks, insurers, healthcare providers, to be able to take care and address disparities in their own way with the levers that they have. So a lot of the stuff that we talk about, that we discuss and have, we either talk about publicly like this or publish in journals or magazines, etc.
So this is now that, thank you very much, Dr. Rawlins, an opportunity for, as we mentioned earlier, for the table interactivity. So now you get to meet the colleagues and who are sitting next to you. If you could work together for about 5-10 minutes tops and come up with a burning question from your table that you'd like to discuss with Dr. Rawlins and Dr. Mort, that would be great. And if you're in the back, you could always, there's room on the tables up here at the front if you want to come to the front. Unfortunately, the clock is never our friend. Let's wrap up your final question.
We still have 25 minutes. Are you driving back today?
Couldn't finish the meeting tomorrow, which is good.
Okay, we're going to have to get started. This is so exciting that no one wants to stop. I love it. Let's get back together to share some of the questions. Okay. All right. This is now like the elementary school cafeteria. Harry! We're going to get started on our question and answer section. And we're going to volunteer. Oh, wow. Okay. All right.
Okay, so I'm Lisa Sloan. I'm from Cincinnati. And we're curious about how the two of you might work together to address a population health issue. So given that working on disparities issues is an opportunity to for systems and for plans to work together, we're just curious, is there a possibility of sharing together claims data, for example, and clinical data to address a regional issue and create a model that might serve as a model for other communities in the future?
Yeah, I mean,
we're assuming that that's not happening.
Well, I guess, actually, we work closely with Joe's group in the Disparities Leadership Center already, but the real issue is, can insurers and other entities work together, I believe. So what I would say is, yes, we're already working actually with the large provider group in Dallas, Fort Worth. It's 100 and something docs. We've actually paid for a diabetic health educator to be on their staff and to see folks and provided her with culturally appropriate and linguistically appropriate information. The real issue around health plans and other entities working together is, does that entity have a lot of that health plan's membership? Aetna does not have a lot of business in Massachusetts. Aetna has a lot of business in the metro New York area, New Jersey, Philadelphia, Texas, Florida, California, things like that. So where we can find an overlap where there's a lot of membership and an entity that wants to work with us, yeah. In fact, we're in Delaware, we're beginning to do that with one of the large systems down there, because there are shared interests, shared membership, shared physicians and network, and I think it makes good sense.
What I would say about the collaboration between insurers and providers is that there's a lot of area for improvement and collaboration. And we were just talking while you were having your conversations that if there were enough patients who had Aetna, and Dr. Rawlins saw that my hemoglobin A1C rates in my provider area were not optimal, he could come down and say, we have these interventions and we'll give you a grant. We'll see if it'll work. And if it works, then we know that it works and we can do it in other places. So that's the kind of thing that I think you can fruitfully do. In Massachusetts, we have 3 commercial payers, our big 3, and we have collaborated and tried to coordinate interventions from insurers with interventions from providers. Patients get confused if they get outreach from my practice and then they get outreach from a commercial payer. So we actually have deep collaboration and deep dialogue with our local insurers. But I think your point is excellent, is that it's really not an option. We have to work together in order to solve these problems.
Great question. Another question from another group.
Hi, my name is Chris Rowland. I'm with the Aligning Forces for Quality program in Washington, D.C., and I had a difficult task of trying to combine 8 burning questions into one great big ball of fire. So bear with me, please. We were interested in knowing what outcomes specifically that you've been able to see moved, what gaps you've been able to narrow or close, and we're especially interested in what you've been able to do around readmissions. And I guess the flip side of that question would be, especially for Aetna, for the 70% of your members that you don't have data for, how are you able to address disparities within that population? Since many of the people in this room, I'm going to guess, don't have race, ethnicity, and language data on their patients, how can you get started without data?
Well, as far as what we've measured in terms of outcomes, I think we probably measure more process indicators than actual outcomes, but that would be for all of our patients. And I'd say we have focused on screening measures and chronic disease management measures. So many of the things that we both were talking about today, looking at mammography, looking at colorectal cancer screening, and the like. We have also looked at to see if there's disequity rather, in certain areas where we haven't found it, and therefore we haven't done any work to close the gap. But those are the areas that we've been focused on over the last several years of our journey. Readmission rates is tough. Readmission rates is tough. I think it's a very stubborn metric, and the metric that we're using, I'd love for it to be refined so the denominator was avoidable readmissions as opposed to all readmissions. But I would say I wish I had a better story to tell you there. I don't think we've made nearly as much headway as we'd like for any of our patients.
Couple of things regarding outcomes. As Elizabeth said, most of the things you have are process measures, so improving mammography screening rates, improving hemoglobin A1C for diabetes, improving hemoglobin A1C, LDL, and blood pressure. For asthma, decreasing ER visits and inpatient visits, and for we do have one outcome measure around hypertension and stroke, if you consider stroke an outcome for hypertension, showing improvements with the culturally competent disease management program. Around the issues about the 1/3, 2/3, yeah, there's a number of people that we do not collect data from. We've actually given ourselves a fairly I'll say a difficult agenda because we voluntarily ask people for their race and ethnicity, which means they don't have to give it to us. And many people decide not to because we're the big bad insurance company and people are very concerned about giving their information to us, which is why we specifically tell people why it will be used and won't be used. We also get race and ethnicity information from nurse outreach calls when we talk to our members, as well as we're doing some work with employers to talk with them about this type of information and how it impacts their employees. And knowing that it will not be, it's not 100% of their employees, we tell them that there are disparities in your employee pool. We can only tell you about a slice of it. If you work with us to encourage your employees to give us this information, we can give you more information and improve the health outcomes of more of your employees. Does that answer your group's questions? I see. Yes? No? All right.
Hi. We had a nice discussion about the complexity of measuring for improvement. What we were thinking about was the patients who are most vulnerable and have multiple comorbidities, especially the elderly. And we were hypothesizing that disparities amongst those people might be even greater because it's a whole bunch of stuff you have to deal with, not just a mammogram or a colon cancer screening. So just wondering how you approach that segment of the population, which, by the way, for insurer is also the highest cost population with the highest rate of readmission. How do you look at your patient population with improvement in mind when they have multiple comorbidities and are frail or elderly?
I think that most people do not have a single condition that defines them. I'm not only diabetic. I'm diabetic, I'm hypertensive, my cholesterol is up, and by the way, I've had 3 heart attacks. So I think many people have the classic medical conditions, whether young, and certainly as it gets worse if they're older, will have complex multifactorial issues. And then you have to layer on top of that behavioral health issues, which are significant because behavioral health issues make everything else worse and more difficult to address. And if you also layer onto that the issues with race, ethnicity, potentially SES, socioeconomic status issues, you have a very complex milieu to deal with. And I think what you need to do is really work, it's sort of, as one would say, hand-to-hand combat, working patient by patient by patient, because each patient's issues will be different. There may be a bucket of diabetic issues or hypertensive issues that are similar, but each individual will be different. And I think when you begin to do outreach, case management or care management, health coaching outreach, one needs to understand those complexities and be able to deal with that on a one-on-one basis. And I think that's the real issue. The cost issues are always interesting because, as they were said upstairs earlier, many times you have significantly underserved populations that may or may not cost you as a health payer or an entity more money, because it's really if they do and how they access the system which generates that.
What I might add to that from the perspective of providing care from the ground level is that when you have a high-risk patient, for lack of a better term, with multiple comorbidities, that patient becomes much more than just a hemoglobin A1C challenge. And the tactic that we found successful here is to embed in our primary care practices a case manager, a care coordinator who's responsible for the high-risk patients. And that essentially boils down to the 20% of patients who are responsible for 80% of costs. We've piloted that here in Boston. We did a demonstration with CMS. We were able to demonstrate a 7% reduction in costs and improvements in quality. That was not so much a focus on equity across gender or race, but looking at patients who really do have a disproportionate burden of disease and socioeconomic challenges. We were talking while you were all huddling about the challenge of having embedded care coordinators to take care of that high-risk population, and navigators. How many types of role groups? And the navigator more focused on cultural issues and navigating around a particular disease. I think we're learning as we go in terms of what kind of individuals we need in practices, how many skill sets you can find in one person, and how many people we can afford. But that's what we're doing to try to get our arms around the more complicated patients.
Just to follow that up, Dr. Rawlins, from an insurer's perspective, how much of your, with these high complex patients, how much percentage extra money do you account for Dr. Mort's program on the embedded case manager and navigator?
I know that actually in our Medicare Advantage program, we're actually embedding case managers in the practice because of that. I think the real issue around high-cost members is interesting, in that if you look at high-cost members just by the dollar amount, it's usually going to be trauma patients, people who drive into trees and are in hospitals forever, and cancer patients. And many of those, by the time that they're placed in an institution, there's little you can do to fix them. So you really need to go way upstream and see what you can do to fix things at that level.
We have time for one more question. I'm sorry, go ahead. Repeat the question.
Try it again.
What I was looking for was whether or not you analyze your data on these very vulnerable patient groups to see how great the disparities are for them, because it could be really shocking. And I know that Aetna can do that. You can model it probably in a day.
Yeah, I mean, right now for our racial and ethnic disparities work, we're specifically looking at conditions, just because it's easier to put things into buckets. I know that other groups of people, specifically are some of our medical cost units, are looking at, I'll say, high utilizing patients or potentially high cost patients to understand what the issues are with them, which is where I got to the trauma people and the cancer people and teeny tiny little babies who are in hospitals for a long period of time. And looking at high cost only sometimes causes you a problem because there's not many times things you can do to fix them. Pardon me? So you're talking about the complex Medicare patients, and in our Medicare area is looking at this, and as I said, for many of those people with complex conditions who are in the Medicare population, we're embedding case managers to understand and assist them. So yes, there is some work going on with understanding what's happening with that, but not specifically around race and ethnicity at this juncture.
And now I understand your question, Don, and I would say that we've looked at multivariable analyses to look at what are the predictors of outcomes. And I'll tell you the strongest predictors, I'm sure race and gender are in those models, but the strongest predictor are things like lives alone, widowed, social supports, those sorts of things. But I'll go back and look at the beta coefficients because I'm sure they're in there now that I understand your question. It's a great question.
For getting me to clarify that one. Do we have time for one more? You said one more. In the back. One of the tables in the back.
Hi. Our table had a thought about how you could work together, hospitals and PCPs and insurers, and that's pay for performance or risk-based contracts. So the question for Aetna is, would you be willing to stratify your quality measures by race and ethnicity for providers? And for Dr. Mort, would you be willing to take on accountability for the quality measures that are in your contracts with commercial insurers or Medicaid based on equity?
I guess from an Aetna point of view, you'd like to have a large enough population that you have statistical power. So telling you have 2 African American diabetics in your practice of 2,000 people is nice to know, but it may or may not make that much difference. And I think that's one of the reasons why if you're trying to stratify quality metrics by race and ethnicity, you need to have an N big enough that you have statistical power to be able to talk to folks, because one of the things that folks that deal with healthcare providers a lot know, the first thing that you do when you give people, doctors, data is they say your data is a bunch of crap. They throw it at you, and then you go back and forth to this iterative process until people realize your data is not a bunch of crap, and then you can have a dialogue about it. So I think having statistical power becomes important. Yes, we do give healthcare practitioners information about all sorts of things, but I think that you need to have enough volume or market share, if you will, in their practice to have them to listen to it. Doctors get information from 13 different health insurance companies about all sorts of things, and when I talk to a lot of my colleagues who are in practice, they sort of chuckle at me about it and say, yeah, I see this stuff, and I throw it in the trash can until something else goes on. But I think as you begin to build volume, a health plan or a large practice that has enough people, that you can be able to talk about things in a statistically powerful or appropriate way, you begin to build traction and be able to have a really cogent dialogue about what's going on and be able to work with providers and provider groups to be able to help them and assist and support them in meeting the needs of their patient population.
I love the idea. And I've been involved in a lot of our pay-for-performance contract negotiations around the quality measures, and that hasn't come up specifically in our commercial payers, but I think I'm going to bring it up as a conversation piece. But I'll tell you, one of the challenges is Blue Cross, as an example, the measure sets that we're working with these days with our ACOs and so on are a little bit packaged. But what I would say is that Mass Health has asked us to, in our pay-for-performance component of the Mass Medicaid payments, they've asked us to fill out a questionnaire that reports on how we're doing organizationally around disparities, including, what's our board composition of race and things like that. So I love that question. I think I'd be absolutely open to it, notwithstanding ends and all that other stuff that you need to be relatively stable for a pay-for-performance. But thank you for asking that question.
Unfortunately, we've sort of run out of time. I mean, unless there's a quick question, I'm getting the 2-minute mark. Does our okay, great.
Yeah, this is kind of going back to really, what building measurement and monitoring infrastructure. So we were talking a little bit about how do you populate you're setting up your database, your dashboards. Talk a little bit about the data that goes in, because what happened in our table, there are all these different populations depending on the practice that you're interested in that people wanted to hear quality measures about. So whether it's pediatrics, whether it's LBGT populations, whether it's socioeconomic status, both of you have dashboards. And I wanted you to speak a little bit about the establishment of the dashboard and the choosing of the data that went into the dashboard and how you change it depending on what outcomes you're looking at.
Well, at MGH, we generate hypotheses, and we measure where we're worried there may be disparities based on the literature, as an example. So that, it's not just let's take everything and report it. Let's look at where we know there are vulnerabilities. So that really drives it, and that was the point I was trying to make. It's not strictly speaking a dashboard. It's really a report that's comprehensive. So I think it would be a combination of, where do you have data, where do you have interested clinicians, and where you don't have data but you're worried, how do you help those areas develop a way to measure? And keep in mind that all measures do not need to be from administrative databases or chart reviews. There's a lot of methodologies for collecting information. Focus group, patient narratives. Those stories are very, very important and very, very powerful. They may not have statistical significance in that sense, but numbers and stories together is a very important source of information.
I mean, I think for health plans, one of the nice things is you have a vast amount of claims data understanding the limits of claims data. It's based on ICD codes and CPT codes, so it's a summary, I'll say, about what really happens. But at least it's a data source. It's standardized between health plans, health insurers. We're able to combine that with laboratory information, where we get laboratory information, pharmacy information, where we get pharmacy information, and align that with the people that have given us race and ethnicity, just race and ethnicity, not other parameters, to be able to understand what's going on around those types of disparities. There are other ways of getting information. Certainly being able to link with electronic medical records is going to be a great thing in the future, or regional information exchanges will be important. And I think understanding outliers becomes important as well. Most planes don't crash, but when one does, people get really upset about it. That's an outlier. So it's really important to understand outliers and not to always dismiss them is what goes on. And I think certainly asking people, focus groups, surveys, et cetera, can also give you different types of information to help you build an effort to be able to improve healthcare quality and outcomes for folks.
Here, other groups are starting to clap. So that's awesome as well. This has been very fruitful. We'll probably be here for another hour, but we have another session to go to. I just want to do one piece of housekeeping, and that is don't forget to fill out your evaluation forms and hand them at the end. And if you have any from earlier today, hand those in as well. Let's give a warm thanks to Dr. Mort and Dr. Rawlins and to yourself for participating. Thank you very much.